The following podcast is part of a certified educational activity titled Advancing Care for Chronic Spontaneous Urticaria, Navigating an Evolving Treatment Landscape for Optimal Patient Outcomes. Access the entire activity and complete the post-test at peerview.com/QPE860. Downloadable slides and practice aids are also available.
Hello and welcome to this activity on advancing care for chronic spontaneous urticaria. I'm Dr. Adam Friedman from the George Washington School of Medicine and Health Sciences, and joining me is the amazing, the world-traveling Dr. Dawn Merritt from Oakview Dermatology.
Thanks, Dr. Friedman. I'm happy to be here today.
So what are our goals for tonight? First and foremost, we are going to enhance your ability to diagnose CSU, distinguish it from urticarial dermatoses to ultimately minimize treatment delays. We're also going to work to improve your understanding of the shortcomings of our current armamentarium to manage CSU. We hope to augment your knowledge on the mechanism of action of our therapeutic options, but along those lines, also dive into the pathophysiology of disease to ultimately translate that to the efficacy and safety of our new therapeutic approaches. And lastly, we're going to provide you with guidance on applying tailored evidence-based strategies to adjust or even advance therapies for your patients with CSU. So let's dive right into diagnosis and diagnostic challenges, which my hope is after our session today, this will be a walk in the park. So why don't we start with some common misperceptions that your patients may present to you when they come in. So I think right off the bat, and Dawn, I'm sure you can relate to this one, a patient comes in, they say, I'm allergic to something. That's what's causing my hives. We got to get to the root cause of this. And if we do, this all goes away. And unfortunately, that's not the case. Historically, chronic spontaneous urticaria was called chronic idiopathic urticaria, which I think gives a little more insight in terms of the fact that there is no underlying cause. You could have comorbid diseases, you could have triggers of disease, but there's not some one underlying thing that's driving it. And actually, there was a recent study that looked at food sensitization and self-reported food sensitization in individual CSU. And while a large percentage of patients reported, oh yeah, I'm allergic to this food or that, actually roughly only 1% of those patients actually had food sensitization. So it is not an allergy. I think there's a lot of confusion in the ether about that. And so that's maybe step one in terms of redirecting patients with education. John, do you get that a lot too?
All the time. Patients always come in and want, allergy testing.
Yeah, absolutely. And that leads to the next kind of misperception that the $1 million workup is needed to make the diagnosis. Absolutely not. The diagnosis is clinical, and we're going to give you the very simple tools and questions and scripting to get to that clinical diagnosis. Now, I will say on your thorough review of systems, if something pops, if the patient's reporting complaints regarding specific systems, then absolutely go down that rabbit hole. But to just kind of throw a million darts hoping to hit a bullseye, that is absolutely not going to aid in your diagnosis. But sometimes certain labs can be helpful to identify comorbidities, not to mention to anticipate the success of certain treatments. We'll get into that. The next one, if antihistamines don't work, systemic corticosteroids are the next step. I have definitely had patients come in and say, just give me one of those packs. Just give me a little bit of prednisone. Dawn, do you get that a lot?
Oh, absolutely. And so many of our colleagues, in other specialties are doing this.
Yeah, it is an easy button. I totally get it. And I like to say, and I tell my patients, giving prednisone is a deal with the devil. They're going to feel amazing in probably under 24 hours. Until they don't feel amazing as they come off of, and especially if those horrific Medrol toast packs, as they come off of it, you will get rebounding. And we see this with a lot of chronic inflammatory diseases. Atopic dermatitis is another great example. So in fact, systemic corticosteroids, whether it be short or long-term, is not recommended in the guidelines. Rather, on-label FDA-approved therapeutics that are now available, let alone even off-label therapies that have anecdotal evidence are recommended over corticosteroids. So just say no. The last one is, and I recognize the concern that CSU will turn into something else, or it's a herald, or it's a perineoplastic process. It is not a precursor for autoimmune disease or malignancy. That doesn't mean that you can't have comorbid disease, but I think, again, we want to distinguish CSU as an independent disease state separate from these other concerning things. Dawn, what's kind of the most common disease state that you hear from your patients in terms of thinking that the CSU is more of a manifestation of?
I think it's probably autoimmune diseases like lupus. Absolutely. A lot of them come in and they've already had $1 million workup. And so oftentimes that's what leads them down that pathway, I think.
Yeah, absolutely. So let's get into some of the easy buttons here in terms of making the diagnosis. So first and foremost, distinguishing between acute and chronic urticaria, which I consider to be completely different disease states, there's a line in the sand. It's 6 weeks. I've been trying to figure out where that 6 weeks came from. I even asked ChatGPT. Nobody knows. It's an arbitrary number, but that's what we have. So this has been going on for longer than 6 weeks. It goes under the bucket of chronic urticaria, and there's several things under that that you see below. The other really important thing is each individual lesion should only last for 24, maybe 36 hours, and then poof, it disappears. Doesn't mean you don't get other ones. And it's really important to specify, because if you just say, yeah, how long has this been going on for? Oh, 12 weeks, 14 weeks. You're not getting to the meat of each individual lesion lasts for a short period of time. Really, nothing else in dermatology does that. And so I think those two questions are hugely important and they need to be very tailored. Now, under the umbrella of chronic urticaria, you have the most common chronic spontaneous urticaria, of which we now know there are these two endotypes. Type 1 refers to autoallergic, meaning there's some autoallergen within you that IgE will latch onto. That autoallergen will cross-link those two IgEs, and then they will bind to their receptor and set the magic off, which Dawn will get into later. So I don't want to steal your thunder there. Type 2B is the autoimmune flavor, which comes with IgG targeting the receptor, IgG targeting IgE, a little more complicated, which is why that type is also a little more complicated to manage. Now, on the other side is inducible urticarias. And it's important to note that patients with CSU can also have inducible urticaria or what is called CINDU. So if you have a patient with CSU, it is absolutely worth doing the bedside fund diagnostic testing for the litany-inducible urticarias here. The most common would be dermatographism, which is scratching elicits the wheal and flare. You can have a lot of fun drawing on your patients. Do it on their back so they don't see what you're scribbling. Cold urticaria, as the name infers, cold-induced, solar from sun, heat, cholinergic, internal increased body temperature from exercise, vibratory. The one I really want to call out, though, is delayed pressure urticaria. Two pieces to this. All the others will happen within seconds to minutes of exposure. This one's maybe a couple hours later. And number two, it's more like angioedema. It is a deeper swelling, so it doesn't look like the kind of geometric dermatographism or in the shape of maybe the dripping from an ice cube or something like that. So that's kind of one of the unique ones aside from the other inducible urticarias. And here are just some examples across the different skin tone spectrum. The more historic textbook description of the wheal and flare you can appreciate on the upper left-hand corner. But often you don't get that perfect circle and kind of pallor in the center. It's often more hemiarcuate, serpiginous. But then in darker skin tones, you might not even see red. Erythema is not red. Erythema is vasodilation, which then you get more blood flow and potentially pink, red. But often you can just see white, as in the upper right-hand corner, where that edema is kind of blanching out the vessels. And so it has a more of a poterange appearance. But you can also certainly see maybe a darker red or purple in darker skin tones. But I think it's really polymorphic. What do you think, Dawn?
Oh, I agree. I think, that's why sometimes, even as dermatologists, we, have to sort of look and look again to make certain that we're making the correct diagnosis.
Yeah. But those key questions, is that spot going to be here tomorrow? Has this been going on for longer than 6 weeks or less? Those are your two best friends when making this diagnosis. Because what you're going to see very shortly is there's a laundry list of urticarial things. All right, let's get into some of the nuts and bolts of the disease state itself. Relatively common condition at any given time affects 1% of the global population. And it's really nice to remember, it's also 1% of the US population. Women seem to have this more likely than men. My feeling is now that there's so much attention to this disease state, we're going to get a lot more epi data. And so these demographic predilections may change a little bit. We've seen that in other disease states like hidradenitis suppurativa, even atopic dermatitis. So I think the jury might still be out as these maybe global surveys are going to be initiated. People who develop CSU can also get angioedema, which I pretty much call a deeper flavor of CSU. CSU plus angioedema is very different than angioedema by itself. We're not even going to get into that. There are a couple of different elements, whether it be hereditary or acquired, totally different disease state, totally different ballpark, but CSU and angioedema can co-occur. On average, it can last from anywhere from 1 to 7 years. In one paper, it found that about 50% of individuals will be clear at 1 year. Sadly, we have no biomarker to predict who will clear and who won't. But certainly the 5 to 7 is a common number that we see in studies. But there's certainly a subset of patients who will have it for 10 plus years. This is an unpredictable disease. And I think that adds to some of the burden you're going to hear about. No other condition in dermatology goes from 0 to 60 in nanoseconds, billionths of a second. You can be on a webinar like we are now, and in moments, head to toe urticarial plaques. So that unpredictability, not knowing when the shoe's going to drop, is going to absolutely add to that burden of disease. Now, this is where I think it's really important to take some time to talk to your patients, because having a comorbidity does not mean one causes the other. And we know this, that with chronic inflammatory skin diseases, whether it be atopic dermatitis, psoriasis, the persistence of an inflammatory burden can lead to other medical issues. And so when we think about, for example, that type 2B flavor of CSU, that autoimmune flavor, well, we know autoimmune diseases, they don't like being lonely. They run in groups. And so autoimmune thyroiditis can come along for the ride. Even type 2 diseases like atopic dermatitis, atopic diathesis, because type 2 inflammation is involved in CSU, you're going to see other T2 diseases. So it's not that one causes the other, rather systemic inflammation can be associated, of course, with other diseases that are driven by similar inflammatory markers. The other thing to note, I find that when you have these comorbid diseases, CSU lasts longer and it's harder to treat. Is that what you're finding too, Dawn?
Absolutely. I mean, I think that goes back, and we'll talk more about that in a minute, is when we look at some of those type 2B patients, they often have some of those associated autoimmune conditions at higher rates, and those are definitely some of our hardest patients to treat.
Yeah, no, absolutely. I'm not going to belabor this. If you think about a disease that can literally come out of nowhere and say, boo, it's going to have every impact on quality of life, right? This is not just a disease that is visible, but the quality of those plaques are certainly very impactful. And this is where a discussion about different flavors of pruritus comes up. Atopic dermatitis, we talk about an itch that feels good to scratch. Urticaria, it's more of a itchy burn, right? These patients feel like their skin is on fire, that it's like there's maybe some little creepy crawlies as well. And so if you're trying to sleep and you have that sensation, you're not going to sleep. If you're at work wondering when your next flare is going to happen, are you focusing on the task at hand? Absolutely not. Are you going to go out with your friends and with the off chance that you may be head to toe and they're saying, what on earth is wrong with you? No, it's going to impact your social life. So this should become as no surprise that CSU is associated with so many psychosocial comorbidities, let alone impact on other metrics of quality of life. And I mentioned sleep. I would say, Dawn, you and I choose probably not to get a lot of sleep. That's just part of our MO in terms of what we do, but we're making that choice. These patients are not. These patients are not getting sleep. And we know sleep is tied to so many medical comorbidities, let alone psychosocial or elements of quality of life. So falling asleep, staying asleep, both are absolutely impacted by this condition. So in diagnosing it, to kind of bring it all together, I think that just purely going on the appearance alone is not enough. It's those questions plus the appearance. Timing is everything. I think those are really important things to consider. Take a careful history. Your first visit with your CSU patient is going to take some time. Get ready to put that investment in, because subsequent visits will be much, much shorter. Really invest early. Think of it like you're putting all that work early to make then that chronic patient, because this is a chronic disease, that's going to make the subsequent visits much easier, and get to obviously all the ins and outs with respect to, whether it be there is potentially some other symptom associated with their flares, if you're going to do a workup based on that, the timing of everything, family history, other comorbid diseases, because at the end of the day, we want to stop this delay that is so well documented. The fact that someone with CSU may go years before the diagnosis is made is absolutely unacceptable. We absolutely can do better, and there are very simple ways to do that. So the 7 aims to really allow us to enhance our diagnostic workup, rule out the differential. And I'm going to go into that in just a moment. Now, if you're talking to a patient, you're like, hey, that spot right there, is that going to be there tomorrow? Is it going to be there in a week? Oh, yeah. Once one comes, it's going to be there for a while. That's a different conversation, which we'll have in a moment. It's good to identify triggers. Remember, CSU and CINDU, they can overlap. So asking questions or even doing diagnostic bedside solicitation of those types of inducible urticaria, fun and very factual and helpful and informative. Comorbidities. We know that type 2 inflammatory diseases can run with CSU, let alone some of the other things we mentioned. So asking about those things, asking about consequences. I think when you start to ask a patient, hey, how's your sleep doing? Are you going out? Like, how's work? That's a way to partner with the patient. I disagree with assess potential biomarkers. There are no biomarkers for this. However, when thinking about labs and being purposeful, and even thinking about the guidelines, certain lab work could be useful. For example, we know, and this is going to come up in greater detail later, that maybe checking an IgE might be helpful in certain circumstances. If a patient is like, hey, I'm getting these hives that come and go, and I have joint pain, maybe checking for markers of inflammation might be useful too. But this is not uniform across all CSU patients. And then also, how are we monitoring for success? Are there tools out there, or is there an app for that, so to speak, to help you monitor these patients over time? So the urticarial differential diagnosis, meaning that a single lesion does not last longer than 24 hours, my apologies, is long for anything from insect bites to erythema multiforme, which is the vascular reaction pattern, urticarial pemphigoid, urticarial vasculitis, collagen vascular disease. The list goes on and on. But again, you're only going to start thinking about these things if a patient's like, yeah, that spot's been there for a week. Also of note, I think when patients come in, they sometimes will have clear skin. And of course, they always will say, oh man, if I was here yesterday, if your schedule was more available, you would have seen it. Dawn knows what I'm talking about. We get that. That's what I say. Let's go to the film, folks. Meaning I say, pull out your phone. I bet you have selfies. Oh, of course. I took people love taking nasty pictures of themselves for some reason. Dawn, do you utilize the selfie in your assessment of this?
Always.
Yeah.
Everyone. I don't think I've ever had a patient in the last 5 years who wasn't able to pull out their phone and show me a picture if they present that day with nothing to see.
Yeah, absolutely. So they often in the moment may forget. So absolutely ask them to pull out their phone. So I think one of the most common kind of maybe difficult conditions that can mirror urticaria or CSU would be urticarial vasculitis. This is probably more of a textbook example. Rarely will you see the purpura. Like, this was such a wild case of urticarial vasculitis on the left. I have never again seen this degree of purpura within these urticarial plaques. The picture on the right is probably a little bit more on point with what you'll see, but truthfully, it could just look like plain old run-of-the-mill urticaria. Again, how long has it been there? And if you're past the 24-hour mark, you are going to do a biopsy for H&E, maybe even for direct immunofluorescence. But that's going to be led by the story rather than, hey, I biopsy all of these. Because for CSU, a biopsy is absolutely useless. It is an invisible dermatosis. Maybe you'll see some neutrophils, but for urticarial things, that's a different story. And I just want to throw together a couple different disease states which have really no overlap with each other that are urticarial. Everything from pseudolymphoma, polymorphous light eruption, eosinophilic cellulitis, tumor lupus. None of these have epidermal change. They're all pink, and they're pretty well defined for the most part. So any one of these, without knowing the story, you could say, well, maybe this is urticaria. But once you get into the meat of it, you can distinguish between CSU and, of course, these entities. Also, as we mentioned, patients may come in and say, I got nothing on my skin today. So the list of pruritus without rash is relatively long. This is why that first visit can be tricky. Now, of course, if they whip out their phone and you see characteristic clinical findings that matches the history and story, you may not need to go down this laundry list. But these are things you have to think about. Itch without rash. Do not put on blinders and think, oh, okay, well, it's gone today. It's itchy, it burns, it got to be CSU. Make sure you're covering everything, because especially you don't want to miss things like lymphoma, which can be a source of itch without rash. So I'm not going to read this for you. This is a table from a paper that I and several of my fellow CSU lovers put together that kind of goes over the different items of that history taking. The citation is below, so certainly you can pull it up. But I think it's great to have a workflow in your mind. You can even maybe create a macro in your electronic medical records that helps remind you of these things. But I think this is really a good way to kind of organize your approach to talking to the patient and what to think about as you're pulling in that data. This is the recommended diagnostic algorithm, and you see on the very top there's that overlap between wheals and angioedema. If there is joint pain, fever, malaise in combination with the urticaria, that is shifting you to maybe autoinflammatory diseases like familial Mediterranean fever is one example. Muckle Wells is another. Gotta love diseases that people have to throw their names in there, right? Gives you no idea of what that disease is all about. Like, fortunately, I think that stopped, right, Dawn? But like when we were in our training, like everything was named after somebody. I'm like, and these names, come on, I can't even pronounce them, right? So I'm very, very happy that a lot of our disease states actually describe their acronyms for what they actually are now, just as an aside. But then if you have a plaque that lasts for greater than 24 hours, now you're going down the route of maybe urticarial vasculitis, less than 24 hours. Is it inducible by some trigger, or is it just spontaneous, as the name infers? That's how you kind of weed your way down this algorithm. And we kind of talked about that already. As mentioned before, I think you're getting the hint that I am really against massive workups. Really should be guided by the story. But in general, we are not doing extensive lab tests. Do not do allergy testing unless there's something in the history that's suggestive. But remember, we're calling it CSU. There is not an allergy. And biopsies, as I mentioned, are really not helpful. Dawn, agree, disagree? Are we going to fight it out now?
Not at all. I would love to have a little duke out, but no, 100% agree. Less is more with CSU.
Yeah. All right. Matt, I thought we are going to have like a fisticuffs over here. All right. You would totally take me too. You're definitely
I don't know
scrappy.
about that. Well, with that, I'm going to take it over. Thanks, Adam, for that great, all of that information is so helpful as we sort of lead into actually working with our patients, helping really understand where they're at in their disease, and then talking about the treatment algorithm and sort of what is available to us as practitioners today for CSU, which is slightly larger than it was about a month ago, which is exciting. So we'll talk about that in just a minute. So, when we talk about the basic considerations in the management of CSU, I think the ultimate goal is that we're able to treat until, in a perfect world, the patient is cleared till their CSU is fully under control. Realistically, though, not every patient is going to get to complete control. So then we're really looking at trying to get sufficient control that the patient can go about living their life with the normalization of their quality of life, sort of, and how they experience the world. That therapeutic approach involves a lot of things. And I think Adam really touched on this that, well, we can look and listen to the patient about potential underlying causes. It's exceedingly rare that we find them. In the last 20 years as a dermatologist, I have found one time where a patient really said to me who had CSU, she said, it really seems to be worse when I eat a lot of dairy, and I really love ice cream and cereal, and I do a lot of that. So she is the only patient where I actually did allergy testing because her review of systems really suggested that that might be useful. And in fact, she had a dairy allergy. But that is once in 20 years. And I'm somebody who sees a lot of CSU patients. But what we can do is help patients figuring out avoidance of eliciting factors. And so those are often those inducible factors that Adam already, discussed. Sometimes it's something as simple as a hot shower and the fact that every time they take a really hot shower, they find that that sort of triggers some of their CSU and makes the itching worse. Or maybe it's stress. I would love to be able to tell my patients just quit having stress, but obviously that doesn't work either. But I think even having a conversation with your patient where you actually identify that stress, while it doesn't cause their CSU, it can make it worse, absolutely helps some of them feel a little less maybe like they're somehow responsible. Because I think often patients feel like that clearly there's something that they're doing. And as we've already discussed, that's not the case. In the end, the goal is to treat them. and to treat them as much as we need to get them controlled, but obviously not to overtreat. And so we'll talk in a minute about some ways that you can figure that part out, how much to treat and when you can actually move on. So, how do we do that? Well, we do have some patient reported outcome measures that I think are really useful. Adam and I discussed this. Adam, you actually use some of these in your practice, don't you, with your patients who come in?
Yeah, no, well, we
Yeah.
haven't got I use the UCT. The UA, I think the UAS7, which you have presented here, gives a better picture given the haphazard nature of the disease. You're capturing over 7 days, which is more realistic because there could be 2 days in a row, 3 days off. So the UCT may not necessarily capture everything, but I'm a fan of the easy button. It's 4 questions, which everyone will see in a moment. This is a little more time consuming. So that's just been from a pragmatic standpoint, that's typically what I use.
So I agree. So the UAS7, which we're sort of looking at here, is really two separate sections. We're going to look at the itch severity score. So we're going to look at that itch and how bad that itch is on a 0 to 3 scale each day. And then we sum that up over 7 days. And we do the same thing with the hives or the wheals. And then when we add those two numbers together, we actually get that combined UAF. And if we do it for a whole week, we get the UAS7. So a total score is from 0 to 42. An ideal outcome is a score with treatment of 6 or less. That means that we're actually getting good control. And a score of 0 means the patient has complete control. And I agree wholeheartedly. This is not something that I do with patients because the reality is I would have to send them home to do this. And most of our patients are not very good at doing that. However, I'm going to show you in a second something that you can use that some patients actually enjoy, and you can get some of this data. The other test that we were talking about that's a patient reported outcome measure is this urticarial control test. And this is what Adam was alluding to that he likes to do in his practice because it is really just 4 questions. You can have this pre printed on a piece of paper that maybe your medical assistant gives to the patient when they come in. You can ask the questions in the exam room. Or in my situation, and I'll talk about in a second, I actually have all of my patients do it on their cell phone because every patient I see today has a smartphone and is capable of doing this. But ultimately, the urticarial control test helps give us data that is quantifiable about how our patient is actually responding to whatever therapy we're giving them. The problem, as we discussed earlier, is that because urticaria is so variable day to day, you really don't want to depend on the patient today. If they're having a really bad day today, and you ask them how the urticaria is doing, they're going to tell you it's terrible. That doesn't give you a very good understanding of how they're doing overall, though, over the last week. Maybe they had 4 or 5 days where they had no hives. And then today, maybe there was something, maybe it's excessive stress, maybe it's something else that led to excessive disease outbreak today. And so the urticarial control test gives us that picture. And so in this situation, we actually want the higher score. So the score goes 0 to 16, and the higher score, the better. So a 16 is the best outcome, which means complete disease control. And so that is what we're really aiming for with our patients. So as I alluded to, there is this application that patients can put on their cell phone. It's called the Chronic Urticarial Self Evaluation Tool or the CRUISE tool. And what I love about it is it's very, very simple. I will actually have a new urticaria patient download this in the office and I will have them walk through it. It takes them probably about 2 minutes to get all the way through the questions. But at the end, it actually gives me 2 scores. It will give me a UAS score for that day, and it'll give me a UCT score for where they're at already because most patients that end up in our offices are already trying some form of therapy. So it'll tell us how well controlled they are today. It is super helpful. Ultimately, it really gives the patient something where they can monitor for themselves how they're doing. The other thing is, if you have a very motivated patient, they can actually do this on a daily basis and it will calculate a UAS7 score. I will admit most of my patients are not that motivated. But every now and then I have a patient who really wants to see what it looks like, and they will bring me their UAS 7 score. There's actually even a way they could email it to you. That's probably beyond what most of us are going to do, but it is that easy way to get that patient reported outcome measures to help guide what you're doing in the clinic. So here's basically how we use the UCT test and that score to decide what comes next. So, an urticarial control test score of less than 12 would suggest the patient is uncontrolled. And in that situation, you're going to step up. So, if you're, let's say this is after your first visit and they've been on fourfold treatment with second generation antihistamines, and they've been on that for, say, 2 weeks. Now you're going to step up to the next therapy, which we'll look at in just a minute, which would be omalizumab. But if their UCT is, say, 14, that would suggest that your patient is really well controlled. And whatever you're doing today, you want to continue to do that. Now, let's talk about treatment guidelines and that algorithm for treatment. This is based off of the international guidelines that were done in 2021. Interestingly, the US guidelines, the last time they were updated was in 2014. Those are actively being updated as we speak. I hope that we will actually have new guidelines later this year, early in 2026. But for now, most practitioners who treat a lot of CSU follow this algorithm. And so we start out with standard doses of second generation antihistamines, and if the patient is not responding well, you step up and you can go up to fourfold the standard dose. If you've done that for 2 to 4 weeks and the patient is still having significant outbreaks, they're not well controlled, your next step is going to add on that biologic, omalizumab. And if that is not significant enough response, you can actually increase the dose of omalizumab or shorten the interval between injections. So rather than 300 milligrams Q4, maybe you step up to 450 milligrams Q2. Now, as much as I love that this is in the guidelines, I will say one of the hardest and most frustrating things for me is when I want to go to a higher dose of omalizumab and I cannot get insurance to agree to it. And I think that is probably, Adam, is that something you find is often frustrating?
Absolutely. Actually, it's funny because sometimes we'll even split, do Q2 week dosing. And even though it's the monthly dosing, if by accident someone happens to put that in the script, it gets denied because it's off label dosing, even though the actual milligram amount is the same for the month. And then, yes, there are patients who I have really fought to get 450, for example. It happens, but it is not easy. I think the most effective way to do that is, one, clearly document, but two, turn to the literature. Turn to reports in the literature and submit that with your prior authorization or your letter of medical necessity. And that's kind of the only way I've been able to succeed. But it's the exception rather than the rule, being able to get that higher dose.
And I agree wholeheartedly, which is part of why I think we're so excited that there are other options coming, because there's obviously patients that are going to need that. And then based on these current guidelines, the next step would really be to add on cyclosporin, which, while it absolutely can work for that subset of patients who fail omalizumab, the problem is a very high percentage, about 20 to 25% of patients end up discontinuing cyclosporin due to side effects, which is a problem. So let's talk about sort of those steps. So when we talk about second generation antihistamines, number one, when we look at standard dose, only about 40% of patients or less are going to respond to standard dose. When we updose somewhere between 2 to 4 times that standard dose, we get maybe 60% of patients who get good control of their CSU. But that means at least 40% of patients, even on 4 times that standard dose, are not getting the control that they really need and deserve. And so we have to move on. The other thing that is interesting, a lot of my colleagues say, well, is one of these better than the other? And there have been a number of meta analyses, there have been a number of review articles. And at the end of the day, I think what most of us find, they're really not hugely different one from the other. I think you pick the one that maybe you have comfort with. I will say the one thing about these, though, cetirizine is known for certain to have a higher incidence of somnolence, and your patients often will complain of fatigue with it. So that is just something to consider. It's typically not where I personally start just because I want to avoid that. I already have a patient who's not sleeping well because of their CSU. I don't want to add daytime sleepiness on top because of the medication I'm utilizing. So my starting drugs are usually either fexofenadine or levocetirizine. By the time they come to see me, most of them have already tried one of these and have already done standard dosing. And then I move to 2 to 4 times. You absolutely need to talk with your patients when you write 4 times the dose and remind them that when they go home and they read the back of their little bottle that they bought over the counter, it will tell them they are only supposed to take one pill in 24 hours. I have so many phone calls from providers in my practice who don't have that conversation. And the patient is like, well, wait, it says I can't take more than once. You have to discuss the fact that this is truly different because we're using it more from a prescriptive sort of standpoint. Now, the next thing, I'm going to kind of diverge just slightly and talk a little bit about pathophysiology. Because as we step into discussing omalizumab, which is our next step in that algorithm, I feel like it's really important for a lot of my colleagues to understand this type 1 and type 2B endotyping that Adam sort of alluded to. And the reason is because patients will have different responses to omalizumab and maybe to other drugs that will be coming down the pipeline or are now approved. Um, but we need to understand why that might be. So type 1 CSU is that autoallergic CSU that Dr. Friedman discussed. And it has a high association with atopic diseases because we're talking about those, auto allergens. And when we do some testing, and this is what Adam sort of alluded to, that sometimes there's a benefit to doing a little bit of testing. If we tested IgE levels, we would find this type 1 group tends to have high IgE or at least upper levels of normal. These patients ultimately tend to have a quick and good response to omalizumab. Now, this group, this type 1, makes up 40 to 50% of CSU patients. So, if you have 10 patients come in, at least 4 to 5 of them will be in this group, and they will be really good responders to omalizumab. When we look at type 2B CSU, which is the other group, which you kind of already anticipate, they don't respond as well to omalizumab. No, fortunately, this group is it's probably less than 10% of all CSU patients, but this group is slightly different. These patients get cross linking that's induced by IgG autoantibodies that are against that high affinity receptor or to against that high affinity receptor bound IgG. And so these patients, as we discussed earlier, have a high association with autoimmune diseases, the most common being vitiligo and Hashimoto's thyroiditis. And when we look at these patients, they tend to have lower total IgE levels, and then they have that poor response. The interesting thing is when we talk about labs, the one place that sometimes is useful that some people will do, and I have absolutely done this myself, is you can do an anti-TPO, which is the most common auto allergen for type 1 CSU. You can do an anti-TPO level and you can do an IgE level. And if you have a patient who has high anti-TPO, especially to IgG, and low IgE, you kind of know out of the gates that they're probably going to be a patient who's not going to respond to omalizumab very well. And that may help you in your conversation with your patient. But I would say the vast majority of dermatologists and allergists are not doing these labs. Adam, when you have a CSU patient, are you ordering anti-TPO and IgE?
Not typically initially. Sometimes I will. The other thing, when I think about doing the thyroid function tests or antibodies, early in my career, I'd get these, positive antibodies for normal thyroid function. I'm like, well, what do I do with this? And I actually at the time was sharing an office space with endocrinologists. Said, hey, what do you do? And they're like, nothing. Like just because you have antibodies doesn't mean you're actually going to have thyroid disease. It's only if there is actually abnormalities with thyroid function are you going to do something. So I tend not to. I think it's more when I have a patient who maybe is not responding as well, then I start to do some blood work to see all right, well, what's the reason for this? And will those tests actually help me throw you into one bucket or another? But more often than not, I'm not checking these.
And if you were paying attention to my percentages, type 1 is about 40 to 50% of patients, type 2B, about 10% of patients. Everybody else is in the middle and they have that overlap. And so that's kind of what Adam was alluding to. And so there's a lot of patients where they're really not going to respond like either type specifically. So we're still learning more every day about CSU. Now, let's talk about omalizumab. So Omalizumab, I think all of you know, anti-IgE monoclonal antibody. It was approved in 2014 for patients 12 years and over with CSU who did not have what we would call satisfactory response to antihistamines. Now, interestingly, in the dermatology world, less than 6% of dermatologists are actively utilizing omalizumab. And part of that is because omalizumab has a boxed warning for anaphylaxis. I'm not going to spend a lot of time talking about it. I think most of you probably already have a fair amount of understanding and knowledge. But ultimately, the data is actually relatively strong for the use of omalizumab in our patients, which is why it's part of that treatment algorithm. So, Asteria 1 and 2 were the pivotal trials, and Glacial was a trial looking at really the adverse events and those SAEs that were found during the trial itself. When we look at outcomes, what we find is that omalizumab from the clinical trials, now these were over 10 years ago, what we find is about 60% of patients were able to get that UAS 7 of 6 or less, which we said was the sign of good control. And about 40% of patients were actually able to get complete control with omalizumab at 300 milligrams Q4. Now, we do have, because the drug has been on the market for well over 10 years now, we do have real patient studies and real life studies that sometimes show these outcomes to be slightly higher than what we even see here. But at the end of the day, I think the important part is while about 40% of patients get complete control, 60% of patients aren't able to get there with omalizumab, which, when it was first released, I was ecstatic that we were finally going to have something. And what I didn't really realize out of the gates in 2014 is that there's going to be this subset of patients which are the really hard to treat patients who really needed something more. And so, what are our current challenges? Well, I think number one, it's just not getting utilized to use omalizumab. I think we already touched on the fact that a fair number of patients don't respond like we would like with omalizumab. And we know that those type 2B patients are going to be much, much harder to treat. And then when we think about using cyclosporin, we can absolutely step there after omalizumab. But as I already said, we do run the risk of side effects. And patients can't be on cyclosporin for the next 5 or 10 years, which we've already said some of these CSU patients really and truly will have their disease for not weeks, months, but years that we need to consider therapy for. So, our current treatment options are not as effective as we'd always like. We know that about 60% of patients aren't going to get complete control with second generation antihistamines. And we know that about 55% of patients on omalizumab are going to have either that delayed or inadequate response. And so it really leaves us in a place that we need other options. So, I think when we look at this, this is really looking at the underlying mechanisms and more exciting from my perspective, the therapeutic targets for CSU. So we're really learning more about CSU every single year. And as you see here, CSU is a very complex system, and there's so many different potential targets. As you see on here, there are things that you might recognize. Dupilumab, which we'll talk about in a second. Many of you have probably already heard of a drug called remibrutinib, which we'll also talk about in a second. But I think what is really exciting, not only for me as a dermatologist, but for many of my patients, is that there's so much interest and so many opportunities that I really think we'll be having a completely different conversation 10 years from now. And I'm excited to see how we are able to change those treatment guidelines so that we can really get a much higher percentage of our patients under complete control in a much quicker period of time. So, if you'll take a second, we're going to go ahead and watch this 3D animation that talks about the role of type 2 inflammation in CSU.
Chronic spontaneous urticaria, or CSU, is a mast cell driven skin disease characterized by the recurrence of transient wheals, also referred to as hives, angioedema, or both for more than 6 weeks. Several mechanisms have been investigated as possibly contributing to the pathogenesis of CSU, including infections, food intolerance, coagulation cascade, genetic factors, and autoimmunity. In type 1 autoimmune CSU, IgE autoantibodies to autoantigens, such as thyroid peroxidase and interleukin 24, activate mast cells to secrete vasoactive mediators, cytokines, and chemokines. These, in turn, activate endothelial cells, increase vascular permeability, and promote the migration of blood cells to the dermis. In type 2b and 3 autoimmune CSU, IgG autoantibodies to the IgE receptor, or IgE itself, activate mast cells with the same consequences. Two IgG molecules in proximity activate complement type 3 to liberate C5a, which augments mast cell secretion and is a separate chemotactic factor for granulocytes and monocytes. The rationale for the development of new agents to be tested for putative efficacy in CSU is dependent on assumptions about which of the aforementioned contributions to hive formation can be inhibited to significantly suppress symptoms. Biologics that are currently approved or under development for the treatment of patients with chronic urticaria aim to reduce mast cell activation by blocking activating pathways or engaging inhibitory receptors or mast cell numbers. Biologics that are currently approved for other conditions are also being approved or evaluated for the treatment of chronic spontaneous urticaria. Dupilumab is a fully human monoclonal antibody that inhibits the signaling of the IL-4 and IL-13 pathways. IL-4 and IL-13 are key and central drivers of the type 2 inflammation that plays a role in asthma, chronic rhinosinusitis with nasal polyposis, atopic dermatitis, eosinophilic esophagitis, prurigo nodularis, and CSU. The development and launch of novel agents for chronic spontaneous urticaria are encouraging for patients unresponsive to current treatments. As newer agents become available, clinicians need to understand both the target and therapeutic mechanism in order to better select appropriate patients for these therapies.
So that leads us to talk about dupilumab. And many of you may realize or have already seen the press release. On April 18th of this year, dupilumab got the FDA indication and the approval for CSU in patients 12 years or older in whom they were not having satisfactory response to treatment with second generation antihistamines. For me, this is super exciting. It means we now, as of today, we have another treatment option for our patients. So the studies that were done to get that indication were the Liberty Cupid studies. And when we look at that, they were really looking at adults and adolescents 12 years and older who had that refractory CSU, even with those H1 antihistamines. We're going to look at some of the data in a second. But when we talk about the primary endpoint, they were looking at that ISS7, that itch severity score. That is from that patient reported outcome measure we talked about earlier. The ISS7 plus the HSS7 make up that UAS7 that we talked about. And so that was the primary endpoint that they used to get the indication. When we look at how the drug actually did, what we find is that ISS7 change from baseline at week 24. We see a really robust change for the dupilumab arm over the placebo arm. And when we look at and think about what that means for our patients, what they found is that they really had a significant reduction in itch and hives for CSU patients. And what's really exciting is it didn't matter what the baseline IgE level was. And so, what that suggests is even those patients who have that low IgE level that might be associated with type 2B disease, in those patients, we were able to see good, significant outcome. It didn't matter, it didn't make a difference in the outcome. The other thing, from a safety standpoint, the overall rates of adverse events were exactly and similar to what we all expect that we see in dupilumab patients for other disease states. So when we look at this, so there were actually three studies. There was study A, study B, and study C. So study A and study C were both biologic naive CSU patients. And when we look at that, those were the two that were actually submitted to the FDA for the actual approval. And so when we look at that, we find that the proportion of patients with well controlled or complete response was significantly higher than what we found in the placebo arm, as you can see. But we found that nearly 60% of patients were able to get some really good control with dupilumab. The other exciting thing is there is actually a Cupid Kids study, and this study is looking at children 2 to age 12. This is actually a pharmacokinetic study that looked at adverse events and SAEs in children, but this study concluded in February. The results have not yet been presented. However, we hope to see the results of this soon. And ultimately, as I think what we all hope for, is that this actually will translate in the future to an approval for dupilumab in our CSU patients down to 2 years of age. One other drug I want to touch on is a drug called remibrutinib, which is a BTK inhibitor. So many of you may have not even know what a BTK inhibitor is because in dermatology there aren't other BTK inhibitors. But Bruton's tyrosine kinase is actually a kinase that lives intracellularly within the mast cell. And the really useful piece of this is that it doesn't matter how that mast cell gets activated by those high affinity IgE receptors. It doesn't matter if it was a type 1 response or a type 2B response. Ultimately, BTK is actually in the middle between that and degranulation. And so if we can block that, we can actually block all of those ways that that mast cell can actually be activated. So BTK is a really nice target when we again want a way to target CSU patients regardless of that underlying endotype. So remibrutinib is a BTK inhibitor that we now have phase 3 data has been actually released. They do not have an FDA approval at this time, but we do have the data. And one of the nice things about BTK is that remibrutinib is an oral medication. It will be a BID or a twice daily dosing, but it will be an oral medication. And I think we all have some patients who would like the opportunity to have something oral rather than injectable. And so that's where this may really be something that you would want to use as part of your treatment armamentarium down the road when we get that FDA approval. When we look at the change in UAS7 at week 12, we do see a slightly faster change. And we also, again, see that a significant percentage of patients really improved greatly in their UAS7 with remibrutinib over placebo. From an adverse events standpoint, the drug really was pretty clean, with the exception of some petechiae that occurred in about 3.8% of patients versus only 0.3% in the placebo arm. What I will tell you is a lot of people ask, is petechia mean that there were bleeding issues? And the answer is no. They did not see any true bleeding issues in the clinical trials. It was just some, very small petechia that occurred on the skin, most commonly on the forearms. But ultimately, more to come in the near future about remibrutinib.
Thanks so much, Dawn. That was an amazing overview of our therapeutic options, but also giving some hope for a litany of upcoming therapies. So we're going to wrap up quickly with a case study. So our case study is of a 36-year-old woman who reports a 9-month history of daily or nearly daily episodes of raised itchy wheals, primarily on her arms, trunk, thighs. Sometimes she gets mild angioedema, but I argue she probably didn't use that terminology. The hives resolved within 24 hours. That I will imagine was solicited by the physician or the extender working with her, but wouldn't it be lovely if the patient came in with all this information, make our job a little bit easier. These recur without any clear trigger, no identifiable allergen or physical triggers, no systemic symptoms, which is hugely important because we want to think about, is this part of an autoinflammatory disease, whereas a standalone? Shocker, sleep disturbances, impacts productivity, mood, you name it, past medical history, some signal of a T2 component with mild allergic rhinitis, and no history of autoimmune disease or thyroid disease. So, given everything we have discussed today, do you feel like any other testing or workup is needed to confirm that Maria has CSU?
I wouldn't do much else. Would you do much else, Adam?
I feel like this is where we're like Law and Order. I'm leading the witness here, right? Like that history is about as textbook as you can get. Now, in the real world, are you going to have all that information? Well, our hope is yes, after we went through all these and what are the things to ask. But often when you're presented with this, you may not have all this information. But given all the information we were given, I would do literally zip. I would do nothing else. We have enough information to feel comfortable calling the CSU. So for treatment, past 9 months, Maria had been taking cetirizine at standard doses, and she then begins taking it at 4-fold the recommended doses, but symptoms persist after 4 weeks of regular use. At this point, Maria agrees to try omalizumab, 300 milligrams every 4 weeks, which is the standard dosing, and on label. Response is transient. However, flares resume after about 2 months. She then remains on it for another 4 months, which I want to say I appreciate. We should never, shoot from the hip and say, oh, wow, in a month or two, it's not working. Let's switch gears. You got to give it some time. And I think that's perfectly reasonable. 6 months. I would maybe even say 3 to 6 months, but I think this patient has been given a reasonable time point to really give it a fair shake. Also still taking high dose antihistamines, which, yes, you're not transitioning from one to the other. You are adding on. So if I had a patient failed 4-fold the recommended dosing, I'm adding on omalizumab on top of that, not stopping antihistamines and switching over. Was given oral corticosteroids. Nope, we're going to try not to do that. I mean, there's certain times I get it. You just have to, but that should be the exception rather than the rule. Dawn, what do we do now?
Well, that's the million-dollar question, right? I mean, in a perfect world, if we follow the guidelines at this stage, we would try and step up therapy. We would go to a higher dose of omalizumab, or we would shorten the intervals between injections. However, given the approval of dupilumab, personally, that is what I would do. I mean, what would you do at this stage, Adam?
Yeah, it's tough. So right, maybe mid-April, I would either try to get approval for a higher dose omalizumab. I might. So I really like mycophenolate mofetil in this setting. It's not in the guidelines, actually European guidelines. So they only think about cyclosporin. They love cyclosporin in Europe, and I get it. It works well. But then at the same time, you mentioned this before, there was a paper that just came out that whether someone responds to cyclosporin or not, they should be off of it in 6 months. So what do I do in 6 months from then, right? So I do like mycophenolate mofetil. I have used methotrexate, but now we do have dupilumab. So if someone is not getting that improvement, maybe we're thinking more type 2B, then I probably would consider switching over to dupilumab at this point, still on that 4-fold recommended dosing of antihistamines.
Now, would you ever, do you ever add things? So, like if you have a patient who is on omalizumab and maybe they're getting some response and you can't get them up dose, you're not able to get insurance to agree to let you go to a higher dose, because that's the ideal patient, right? The patient who's already having some response, we're just not getting them quite where they need to be. That's the patient to really, in an ideal world, we would bump them or shorten the interval. Do you ever add oral medicines to that then, some of our older small molecule drugs like mycophenolate?
Yeah, absolutely. And then thank you for asking that, because I want to clarify. When I say that if they're not, in this setting, they're not cutting it, I'm adding, just like I said, antihistamines, you add omalizumab on top. I'm adding mycophenolate, not taking them off omalizumab and going to mycophenolate. So I take this approach similarly with hidradenitis suppurativa, atopic dermatitis. We are adding things on until we get to clearance. You had that beautiful slide that said we treat to clearance. I'm adding until we get clearance. And then if they're free and clear for about 6 months, I start pulling things away. So that was a great question. All right, we went through quite a lot in a short amount of time, but I hope we've impressed upon you some key approaches to A, diagnosing CSU and distinguishing it from urticarial things, B, how to go up that staircase with respect to our therapeutic armament, which for way too long had been quite limited, but is expanding. And honestly, I mean, I'm sure, Dawn, you share this enthusiasm. It's an exciting time to manage CSU. And I think our hope is that with these new options, we'll be able to pull more of our colleagues into the CSU fold and also welcome these patients into our practices. But no question, there are still challenges here, which makes this exciting and fun. But as we get new approaches, and I find we learn so much, when we have a new drug with a new target, we actually learn a lot about the underpinnings of disease too. So CSU is absolutely hot right now. And I hope that you take even a few of these nuggets back to your practice tomorrow and help these patients because they certainly need it. So with that, I thank you so much for joining us today. And thank you, Dr. Merritt. That was an incredible overview of the therapeutic approaches, providing your personal insights and anecdote experience. We hope you found this activity to be useful to your practice. Thank you all for joining us.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical education grant from Sanofi and Regeneron Pharmaceuticals. To access all materials for this activity, visit peerview.com/QPE860.